Okay, so it's 2 o'clock, so we'll go ahead and get started. My name is Brittany Allison. I'm a PGY2 emergency medicine pharmacy resident here at Advent Health Orlando. Neither I or my advisors have anything to disclose for this presentation. This is a continuing education presentation brought to you by the University of Florida College of Pharmacy. Here's a list of the regularly scheduled objectives for this series. And in order to receive credit for this continuing education presentation, you will have to fill out the evaluation that will be sent out later today. The topic of my presentation today is critics of lytics, fibrinolytics, and anticoagulated patients. The objectives for my presentation include assessing fibrinolytics' place in therapy for acute ischemic stroke, discussing the current guideline recommendations for the use of fibrinolytics in patients who are receiving anticoagulation, looking at laboratory values that can be used to identify patients who may be eligible for fibrinolytics, reviewing anticoagulation reversal and their role in patients who are otherwise eligible for fibrinolytics, and to evaluate the current literature available for the use of fibrinolytics in anticoagulated patients. Here is a list of abbreviations that will be used throughout the presentation here for your reference. So a cerebral vascular accident, also known as a stroke, occurs when blood flow is reduced to the brain. This topic is important to us as healthcare providers because strokes are a common occurrence worldwide with about 12 million events and 6.5 million deaths every year. Nearly 800,000 strokes occur in the United States annually. And in fact, statistically speaking, if you look to your left and right, 1 in 4 people in this room will have a stroke in their lifetime. Here at Advent Health, we treat patients with strokes on a daily basis. Strokes can be categorized into ischemic or hemorrhagic. Hemorrhagic strokes occur due to a bleeding vessel that leads to reduction in blood flow to an area of the brain. Ischemic strokes, which will be the focus of today's presentation, occur due to a blockage, often atherosclerotic or embolic in nature, and completely block or partially block a blood vessel, occluding blood flow to an area of the brain. So when we're evaluating patients presenting with ischemic stroke, symptoms are often assessed using the National Institute of Health Stroke Scale, or the NIHSS. As you can see, the scale directs providers to assess various potential stroke deficits and assigns a score based on the severity of that deficit. The score can be used to measure neurologic function and deficits and help us determine the severity of a stroke. So a score of 1 to 4 would be a mild stroke, 5 to 15, moderate, 16 to 20, moderate to severe, and then 21 to 42 would be considered a severe stroke. This score can be measured at baseline and also multiple times throughout the patient's stay to assess changes in neurologic function. Imaging can also be used to help us determine if these symptoms are being caused by a stroke. So a CT scan is effective at excluding hemorrhagic strokes and can be able to show evidence of larger ischemic strokes. While CT scans are effective, they may be helpful. Not all strokes can be found on a CT scan. So an MRI is needed to diagnose smaller strokes and is our gold standard for stroke diagnosis. Unfortunately, MRI imaging is less readily available and can take an extended period of time to complete, which is not an option for our patients in the acute treatment setting. The Modified Ranking Scale, or the MRS, is used to evaluate outcomes in clinical disability. Ischemic stroke literature often uses the Modified Ranking Scale to evaluate long-term outcomes and can be helpful when comparing disability outcomes across multiple different studies. The scale ranges from 0 to 6, increasing with disability with larger scores. And the MRS of 0 to 1 is often used as in our stroke data as a good clinical outcome. Treatment options for ischemic strokes include the administration of intravenous fibrinolytics, mechanical thrombectomy to physically remove the clot from the obstructed vessel, or antiplatelet therapy with aspirin and/or P2Y12 inhibitors. Each of the treatment options has specific eligibility criteria, and a patient may be eligible for one or some combination of treatments. The focus of today's presentation will be on fibrinolytic therapy. Fibrinolytics include alteplase, tenacteplase, streptokinase, urokinase, and reptoplase. Alteplase and tenacteplase are agents that are clinically used in practice today because of their increased fibrin specificity. If we look at the clotting cascade, we can see the intrinsic pathway and the extrinsic pathway work together towards a common pathway and result in this creation of fibrin-linked clots. Plasmin is responsible for the degradation of these fibrin clots, and fibrinolytics convert plasminogen to plasmin, leading to an increase in breakdown of those fibrin clots. Fibrinolytics do have strict eligibility criteria that's outlined in the AHA and the ESO guidelines. Treatment with fibrinolytics are indicated in patients who have severe strokes or those with more mild strokes where there are disabling symptoms. Patients are also required to be presenting within 4.5 hours of stroke symptom onset. However, the ESO guidelines do add a recommendation for patients presenting within 4.5 to 9 hours and have a perfusion mismatch seen on imaging. While it is important to note that inclusion of those patients between 4.5 to 9 hours is not the standard practice here at Advent Health. There are an extensive list of contraindications for the use of fibrinolytics, including but not limited to active bleeding, a history of intracranial bleeding, a history of ischemic stroke within 3 months, specific risk factors for bleeding, infective endocarditis, and anticoagulation. The contraindication we'll focus on today is the use of fibrinolytics in our patients receiving anticoagulation. The guidelines give us specific recommendations for patients who are on anticoagulation. So patients taking warfarin are able to receive fibrinolytics if their INR is less than or equal to 1.7 or their PT is less than 15 seconds. Patients who have received low molecular weight heparin within the previous 24 hours at treatment doses should not receive fibrinolytics. Patients who have a normal renal function and received a direct oral anticoagulant within 48 hours should not receive fibrinolytics, but they do add that we can consider in our DOAC patients if there's normal laboratory values, and we'll discuss that in more detail later in the presentation. So when we look at the recommendations for fibrinolytics and other indications, we see their use is more accepted. Anticoagulation is a relative contraindication for the use of fibrinolytics in our STEMI patients and our pulmonary embolism patients, while it's an absolute contraindication for the use in acute ischemic stroke. This is likely due to the increased risk of hemorrhagic conversion and intracranial hemorrhage in our patients with acute ischemic stroke. The risk of symptomatic ICH is around 7% in our stroke patients compared to 1% in our STEMI patients and 2% in our pulmonary embolism patients. So I do have a few assessment questions throughout the presentation that you can log into Poll Everywhere to answer, or you can just answer along in your head. So our first question is, according to the current AHA guidelines, which of the following patients would be eligible for the treatment with fibrinolytics? A, patients presenting within 5 hours of symptom onset. B, patients with a history of ischemic stroke 1 month prior. C, a patient taking apixaban with the last dose being 36 hours ago. D, a patient taking warfarin with an INR of 1.5, or E, none of the above. And I'll give you a second to answer the question. Okay, so our correct answer here is D. Patients taking warfarin are eligible if their INR is less than or equal to 1.7. The AHA guidelines recommend fibrinolytics in patients within 4.5 hours of symptom onset, so A would not be correct. They also recommend against treatment for patients who had an ischemic stroke within 3 months, and recommend against fibrinolytics in patients taking factor Xa inhibitors, such as apixaban in this question, within 48 hours. So approval studies for fibrinolytics excluded patients on anticoagulation due to the theoretical risk of increased bleeding in these patients. Fibrinolytics do have a significant risk for major bleeding, but it's unknown if the addition of anticoagulation affects this risk. Anticoagulation may be a beneficial addition to fibrinolytic therapy by preventing additional clot expansion for our patients with acute ischemic stroke. And the use of this combination is controversial and is often avoided in clinical practice based on those guideline recommendations that we talked about previously. Argatroban is a direct thrombin inhibitor, So it works in a different area of the clotting cascade as compared to fibrinolytics. And it was theorized that argatroban may provide additional benefit for our patients. While argatroban does not provide clot breakdown like fibrinolytics do, it may prevent additional clot expansion. So this is the ARTEST-2 trial. It's a multi-center randomized controlled trial assessing the use of argatroban in combination with fibrinolytics. They included patients that had large vessel occlusion or an NIH score of greater than or equal to 10, and who received alteplase within 4.5 hours. They excluded patients who received mechanical thrombectomy, and they randomized patients into 3 groups: low-dose argatroban plus alteplase, high-dose argatroban plus alteplase, or alteplase alone. The primary outcome was a modified ranking score of 0 to 1 at 90 days, with a secondary outcome of symptomatic ICH within 48 hours. The trial was stopped early because a limited number of patients were meeting eligibility criteria due to the increasing widespread availability of mechanical thrombectomy. And because of this, only 90 patients were included. So when we look at the results, more patients had a modified ranking score of 0 to 1 at 90 days in the groups that received argatroban compared to the group that did not. There was no significant difference in the number of symptomatic ICH between the argatroban groups and the alteplase alone group. Although the 10% seen was higher than what was seen in alteplase approval studies, this may just be due to the small sample size. The study does have several limitations, including that it did not meet power and the results were insignificant and had wide confidence intervals. But it is reassuring from a safety perspective that the rates of symptomatic ICH were similar in both groups. This study is added here to be thought-provoking as it may show potential safety of the use of anticoagulation in combination with fibrinolytics. So today there's a wide variety of oral anticoagulants and reversal agents, but prior to the 21st century, warfarin was the only oral anticoagulant that was available for several years. Alteplase was FDA approved for the use of acute ischemic stroke in 1996, and at that time, warfarin was the only oral anticoagulant available. Patients taking warfarin were excluded from approval studies, and warfarin was originally an absolute contraindication to the use of fibrinolytics. The AHA continues to recommend against the use of fibrinolytics in patients taking DOACs due to the lack of randomized controlled trials assessing their safety and that perceived increased risk of bleeding with their combination. So now we'll discuss some literature that's available for the use of fibrinolytics in patients on warfarin and how the risk of symptomatic ICH compares between patients taking warfarin and those on direct oral anticoagulants. So the first study is an observational study that looked at the AHA stroke registry and included patients that received fibrinolytics and who had taken warfarin within the previous 7 days and had an INR that was less than or equal to 1.7. The primary endpoint here was symptomatic ICH within 36 hours as defined by imaging and investigator-determined clinical deterioration. Greater than 23,000 patients were included, with about 7.7% of those patients receiving warfarin, and those patients had a median INR of 1.2. 269 of those patients had an INR of 1.5 to 1.7. The warfarin group did have patients who were older and had more comorbidities. But when we look at the results, symptomatic ICH did occur slightly more in the warfarin group at 5.6% versus 4.6%, but that difference was not statistically significant. After adjusting for ICH risk factors such as age, sex, race, baseline NIH, blood pressure, and blood glucose, there was not a difference in symptomatic ICH between groups. There was a subgroup analysis done with those patients I mentioned earlier that had an INR of 1.5 to 1.7, and symptomatic ICH occurred in 7.8% of those patients. So while slightly more than our other patients at the 5.6 in the warfarin group overall, 7.8% is similar to what was seen in our approval studies in patients not anticoagulated. So overall, the warfarin group did have similar bleed rates compared to patients not taking anticoagulation, and this may be due to the low median INR and the fact that patients were included if they had taken warfarin within 7 days. This was a retrospective review, but it does suggest that fibrinolytics can be used safely in patients on warfarin that have an INR of less than or equal to 1.7. So over a decade after alteplase was approved, the first direct oral anticoagulant was approved in 2010. Factor Xa inhibitors include apixaban, rivaroxaban, and edoxaban, and work in the common pathway of the clotting cascade to inhibit factor Xa, which is responsible for the conversion of prothrombin to thrombin. Dabigatran is a direct thrombin inhibitor that reversibly inhibits free and fibrin-bound thrombin, which is responsible for the conversion of fibrinogen to fibrin. So as we have all seen in clinical practice, the use of DOACs has increased rapidly over the past decade since their FDA approval. And this increase may be due to the increase in population age, increasing incidence of atrial fibrillation, and the rapid transition from warfarin to DOACs for many of our patients. Historically, warfarin was the oral anticoagulant of choice. With approval of DOACs that require less monitoring and have better risk-benefit profiles, there has been a change in the standard of care for disease states such as atrial fibrillation, pulmonary embolism, and venous thromboembolism. This rapid increase in DOAC use over the past decade has led to an increase in our stroke patients who are taking these medications. And in fact, 1 in 6 of our patients that present with acute ischemic stroke and are otherwise eligible for fibrinolytics will be taking a DOAC. So the use of DOACs within 48 hours of stroke onset is a contraindication, as we mentioned earlier, to the use of fibrinolytics due to this theoretical risk of increased bleeding. This theoretical risk has been extrapolated from warfarin studies. However, DOACs do not have the same risk of ICH as warfarin does. DOACs have been shown to have less of a risk of symptomatic ICH than warfarin in our general population. So this was a meta-analysis that included 55 randomized controlled trials showing a significant decrease in ICH between patients taking DOACs compared to those taking warfarin, with about a 30 to 60% reduction in symptomatic ICH seen in our DOAC group. However, it is important to note that after sensitivity analysis, the risk was similar to warfarin for apixaban and edoxaban, although this analysis eliminated studies that had the largest population of patients, so it might be unreliable. Animal studies have looked at the use of fibrinolytics in combination with oral anticoagulation. They compared outcomes and the risk of ICH between DOACs and warfarin. These studies were conducted in mice or rats, and subjects were pre-treated with anticoagulation or placebo, and an MCA occlusion was induced. 2 to 3 hours after the occlusion, fibrinolytics were administered. In each study, patients who were pre-treated with DOACs had less ICH compared to those pre-treated with warfarin. The Plume study did find more blood-brain barrier permeability in the subjects who were treated with warfarin, which may correlate to some increased risk of bleeding in those warfarin patients. So next, we'll look at laboratory values. PT and INR are routinely used for patients who are receiving warfarin, but laboratory values are a lot less straightforward when we look at patients who are receiving DOACs. So the AHA and the ESO guidelines outline laboratory value considerations for our patients who are taking DOACs within 48 hours. The ESO consensus statement recommends us to consider fibrinolytics in patients on thrombin inhibitors who have a thrombin time of less than 60 seconds, and for those on factor Xa inhibitors with an anti-Xa level of less than 0.5. The AHA has a broader recommendation to consider fibrinolytics when laboratory values are normal, but they do give us some potential examples of some tests such as APTT, INR, platelets, the Icarian clotting time, thrombin time, and factor Xa levels. Some of the proposed values for the measurement of DOAC activity are listed here, but not all the ones have been shown to have good correlation with drug levels. For factor Xa inhibitors, mass spectrometry measurements are used to measure drug concentrations and are the gold standard for the measurement of these medications. Unfortunately, this machine is very expensive and is not available at most institutions. So this is a systemic review that assessed the available data for various laboratory tests compared to our gold standard measurements. And of these tests, only APTT, PT-INR, and thrombin time are available here at Advent Health. And as you can see, APTT and PT-INR performed poorly and had little correlation to factor Xa inhibitors or direct thrombin inhibitors. So for direct thrombin inhibitors, such as dabigatran, Thrombin time, dilute thrombin time, and the Ikarin-based assays have been shown to be helpful in our patients taking dabigatran. Thrombin time is a highly sensitive measurement for the presence of dabigatran, and a normal thrombin time, which is normally between 10 to 20 seconds, can be used to exclude the presence of dabigatran. The ESO guideline uses a cutoff of less than 60 seconds, but again, this was from an expert consensus statement that has little data to back it up. Dilute thrombin time is a diluted assay that can be a better determination of clinically relevant levels and has a strong correlation to dabigatran concentrations. The Ikarin-based assay also has a strong correlation to dabigatran concentrations, and Ikarin uses an enzyme from the saw-scaled viper to convert prothrombin to mesothrombin. And mesothrombin is inhibited by direct thrombin inhibitors, but is not affected by other clotting factors or by heparin. So measuring this mesothrombin inhibition leads to a linear correlation to dabigatran concentrations. Unfortunately, neither dilute thrombin time or the Ikarin clotting time are available to be ordered here at Advent Health. Medication-calibrated chromogenic anti-10A activity has been shown to have a linear correlation for our factor 10A inhibitors. However, this correlation was much less specific when they used measures that were calibrated for unfractionated heparin. And when we used those heparin anti-10A levels, they had little correlation to apixaban and variable correlation to rivaroxaban, just depending on the test kit that was used. So anti-10A assays that use drug-specific chromogenic substrate measure PNA, which is a substance that's released from active factor 10A hydrolysis, excuse me. PNA is inversely proportional to the concentrations of factor 10A inhibitors, and the results have been shown to have the ability to come back within 10 minutes, so it would be a reasonable option for our acute ischemic stroke patients. As you can see to the graph on the right of the screen, the correlation was linear for both apixaban and rivaroxaban when compared to mass spectrometry, which was the gold standard. Several societies have commented on anti-10A assays. The ESO expert opinion uses a recommendation for the heparin-calibrated anti-10A levels of less than 0.5 units per ml to be safe for fibrinolytic use. The group on perioperative hemostasis and the International Society on Thrombosis and Hemostasis suggests a plasma level of less than 30 nanograms per ml to be deemed safe for high-risk surgery. So the overall proposed safe level for our calibrated anti-10A levels is less than 30 nanograms per ml. So now we can look at the chromogenic anti-10A levels being used to determine fibrinolytic eligibility. This was a single-center prospective study that used chromogenic anti-10A levels that had specific rivaroxaban calibration. Levels were measured in patients with acute ischemic stroke who were taking rivaroxaban and were otherwise eligible for fibrinolytic therapy. Rivaroxaban anti-10A levels were broken into 3 groups. So levels less than 20 were considered to be low and patients could safely receive fibrinolytics. And levels between 20 and 100 where fibrinolytics could be considered with a risk-benefit analysis, and then levels greater than 100 were high levels and fibrinolytics should be avoided. Outcomes included any ICH, symptomatic ICH, and any major extracranial bleeding. When we look at the results, 63 patients were included, had a median NIH score of 6 and a median time from the last rivaroxaban dose of 11 hours. 18 of those patients received fibrinolytic therapy. 12 patients had low levels and 6 patients had those intermediate levels. No patients that received fibrinolytics had high levels, so greater than 100. Of patients who received fibrinolytics, the median NIH score was 13, meaning these patients may have had more severe strokes compared to the patients that didn't receive fibrinolytics. And the median door-to-needle time was 37 minutes, so still within our recommended time despite measuring these anti-10A levels. No patients in this study had major extracranial bleeding, and no patients had symptomatic ICH. 11 patients who received fibrinolytics had any ICH as seen on imaging, compared to 7% of the patients who did not receive fibrinolytics. The risk of any ICH of 11% is comparable to our previous literature in our approval studies where patients were not receiving anticoagulation. So the study does indicate patients with rivaroxaban that have an anti-10A level of less than or equal to 100 may not be at an increased risk for ICH compared to our patients who are not on anticoagulation. Another strategy that can be used to evaluate patients is the thromboelastography, also known as a TEG. TEGs are used for a wide variety of patients to measure whole blood coagulation. TEGs give us a few different values, but the reaction time, or the R time, is the time to initial clot formation and measures the clotting factor function. And for our patients, R time has been looked at for correlation to DOAC drug levels. We'll further explore the use of R times on our next slide. So the use of the TEG6S system is something that may be an option for these patients in the future. While it's not commercially available yet, there is a cartridge with reagent specific for direct thrombin inhibitors and factor Xa inhibitors. So it has 4 channels, one for direct thrombin inhibitor that uses an Acarin-based assay, one for factor Xa inhibitors that uses human factor Xa, and then the other 2 are similar to our normal TEG. A single center open label observational study looked at the use of TEGs with DOAC specific reagents, and they included patients taking factor Xa inhibitors, those taking direct thrombin inhibitors, and also patients not taking anticoagulation. Baseline demographics were similar between groups, except for that APTT was longer in the direct thrombin inhibitor group. The use of factor Xa reagent, using the factor Xa reagent, R times were significantly higher in patients who were receiving factor Xa, as well as those receiving direct thrombin inhibitors when compared to healthy volunteers. The direct thrombin inhibitor reagent led to prolonged R times only in the direct thrombin inhibitor group, and R times of greater than 1.95 were determined to detect the presence of factor Xa inhibitors with greater than 90% sensitivity and specificity. And the direct thrombin inhibitor reagent had R times of greater than 1.9 determined with greater than 90% sensitivity and specificity for the detection of direct thrombin inhibitors. So if you look to the graph on the right, it would be similar to a pathway you might be able to follow for these patients. So if they have that R time greater than 1.95 in our factor Xa groups, then they're likely on a DOAC. And then further down, you can separate if they're on a direct thrombin inhibitor or factor Xa inhibitor based on your results from that direct thrombin inhibitor assay. The study does come with some limitations, though. Long-term compliance was unknown as they only recorded the compliance of the last dose of the DOAC. And there was no correlation between R times and what dose the patient was on or the time from the last administration. While the sample size was small, this trial does show the potential use for medication-specific TEGs to rule out patients who are actively taking DOACs. Our time results were available within 5 minutes, making this a reasonable option for acute ischemic stroke patients. However, the utility for this would be limited to a small subset of patients where we're concerned for anticoagulation but have limited data on when the last known dose was. So unlike the previous study where patients had been on anticoagulation prior to the study, this one looked at a single dose of a DOAC in healthy male volunteers. It was a crossover study that looked at 9 male patients who were 18 to 70 years old and had normal lab values at baseline. The study evaluated R times using that TEG6S system with our DOAC-specific reagents, and patients were given a single dose of either dabigatran, rivaroxaban, or apixaban. And they measured level at R times at 0 hours, 1 hour, and 3 hours. They found that R times had a linear correlation to DOAC concentrations with R times of greater than 2.5 for dabigatran and apixaban and greater than 1.8 for rivaroxaban, correlating to a DOAC level greater than 50 nanograms per ml. And this did have a sensitivity of 100% and a specificity of 90%. If we compare this recommendation to our 30 nanograms per ml that we talked about earlier, 50 is slightly higher, but it may still be useful in determining anticoagulation. The study noted a time to completion of the TEG took about 30 to 50 minutes, but they were able to see R time results within 3 to 7 minutes. With the possibility of quick results for R times, this test does have the potential to be used for our patients without significantly increasing our door to needle times. This study does come with some limitations, including limited external validity with the exclusion of female patients, and they only included healthy volunteers. They looked at the peak levels of up to 3 hours after the dose, with most of our patients presenting after that time window. If we look at the rivaroxaban study we talked about previously, they had a median time of last administration of 11 hours. So it's unknown if we would continue to see this linear correlation outside of those peak hours. With this new cartridge not yet available, we don't know the cost, but our times may be a good surrogate marker for DOAC levels and may make sense logistically with the portable system and fast results. So that brings me to my next assessment question. So which laboratory values would be the least helpful for estimating DOAC concentrations? A, medication calibrated chromogenic anti-10A activity. B, thrombin time. C, TEG6S R times using medication-specific assays. D, PT-INR. Or E, the Cairn-based assay. And I'll give you a second to answer. Okay, so D is correct. PT-INR does not have good sensitivity or specificity for DOAC use and should not be used as our marker for DOAC activity. Medication calibrated anti-10A levels have been shown to have a linear correlation to factor 10A inhibitors. Thrombin time, while it is too sensitive to correlate to levels, it can be used to rule out the use of direct thrombin inhibitors. The TEG6S system R times have a good correlation to DOAC concentrations, and the Cairn-based assay is a good measure for direct thrombin inhibitor activity. So while anticoagulation reversal has become more widely available, it has been speculated that patients with acute ischemic stroke who are otherwise eligible for fibrinolytics may benefit from the reversal of anticoagulation prior to fibrinolytic administration. These are a few of the FDA-approved reversal agents. Idarucizumab binds irreversibly to dabigatran with 350 times more affinity than dabigatran binds to thrombin. And the ESO guidelines do have an expert consensus statement where 8 out of 9 members suggested idarucizumab plus alteplase may be used in patients taking dabigatran. Idarucizumab is something that is available here at Advent Health. Andexanet alpha is a recombinant human factor 10A variant that serves as a decoy for oral factor 10A inhibitors and binds with similar affinity compared to native factor 10A. In the ESO guidelines, 9 out of 9 members recommended against the use of andexanet alpha prior to fibrinolytics. 4-factor prothrombin complex concentrate, or PCC, is approved for the reversal of vitamin K antagonists and is used at this hospital for the reversal of DOACs. So first we'll look at reversing vitamin K antagonists. So this was a prospective interventional study looking at acute ischemic stroke patients who were otherwise eligible for fibrinolytics and who were taking warfarin but had an INR of greater than 1.7. These patients received 4-factor PCC and IV vitamin K prior to fibrinolytic administration. The primary outcome was safety at 72 hours, which included mortality, symptomatic ICH, and major bleeding events, as well as thrombotic events. 26 patients were included with a median baseline NIH of 11.5, with 16 patients having an MCA occlusion. Initial INRs were between 1.71 and 4.4, with a good representation of patients between 2 and 3.5, which is our therapeutic goal for most patients. None of the patients included received mechanical thrombectomy. 73.1% of patients had significant improvement in NIH score at 24 hours, with 46.2% having an MRS of 0 to 1 at 3 months. No events of symptomatic ICH or thrombotic complications occurred, and one patient did experience major bleeding, but they did have a high INR despite reversal. The median door to needle time for these patients was 82 minutes. So the administration of reversal potentially caused a delay in the administration of fibrinolytics. While this was a small study, it does show the potential safety for warfarin reversal and fibrinolytic administration. So next we'll look at dabigatran reversal with idarucizumab. This was a multi-center case series in Germany that included a total of 80 cases where patients had acute ischemic stroke and were taking dabigatran and then received idarucizumab prior to fibrinolytics. The median baseline NIH here was 9. Of these patients, 78.1 had a decrease in NIH with a median improvement of 7 points. And as you can see to the figure to the right of the screen, the median NIH was 9 at admission and 2 at discharge. So there was trends towards improvement. And this is similar to the improvement that we've seen in alteplase approval studies, which they saw a 5 to 6 point improvement in NIH score. While this case series does show potential safety of idarucizumab prior to fibrinolytics, it can only be used to generate hypothesis as it is a case series and is a low quality of evidence. This next study we will discuss in more detail later in the presentation, but it does provide us a better quality of evidence for the use of idarucizumab, so I'll discuss that here. This is an international multi-center retrospective study that included adult patients with acute ischemic stroke who received fibrinolytics. In this study, 342 patients were taking dabigatran within the past 48 hours, and 254 of those patients received idarucizumab prior to fibrinolytics. Symptomatic ICH occurred in 1.2% of the patients who were on dabigatran and received idarucizumab, compared to 4.1% in patients who were not taking anticoagulation. When they adjusted for ICH risk factors, there was no significant difference in symptomatic ICH between patients on dabigatran who received idarucizumab and those who were not taking anticoagulation. This study was not powered to look at outcomes for this idarucizumab group alone, and it is retrospective in nature, so it allows for some bias that may not have been accounted for in their adjustments. However, it does show the potential safety of the use of idarucizumab prior to fibrinolytics. So we have discussed the use of laboratory values and the use of anticoagulation reversal, all based on the theoretical increased risk of bleeding in our patients who are anticoagulated and that receive fibrinolytics. But it's still unknown if anticoagulation truly puts these patients at a higher risk. We'll discuss the literature next that's available for the use of fibrinolytics in our patients taking DOACs. So when we look at this systematic review, they included patients with acute ischemic stroke and who were receiving DOACs and were treated with fibrinolytics. The first study was a retrospective review of 26 patients. They did not have a comparator group, but symptomatic ICH occurred in 6.45% of patients, so similar to those approval studies. The next two studies compared patients taking DOACs to patients not on anticoagulation and found no difference in ICH. The included case series did not find any ICH in their patients taking DOACs. A meta-analysis was done on those 4 studies and included over 52,000 patients with acute ischemic stroke and 366 patients taking DOACs. The meta-analysis compared patients who were taking DOACs within 48 hours to patients who had taken warfarin and had an INR of less than 1.7, and to patients not taking anticoagulation. Patients who received anticoagulation reversal were not included in this. No differences were found in the risk of symptomatic ICH in the DOAC group compared to each of the other groups. Based on these, because these studies were conducted before the widespread use of DOACs, a limited number of patients taking DOACs were able to be included, so the results did produce some wide confidence intervals. So with the increasing use of DOACs, our more recent studies can provide us a larger patient population. So this is a 2022 retrospective analysis of stroke registries in the United States. Patients with acute ischemic stroke who received fibrinolytics within 4.5 hours were included. They compared patients who had taken DOACs within 7 days to patients not taking DOACs. Their primary outcome was symptomatic ICH within 36 hours of fibrinolytics, and over 160,000 patients were included, with 2,200 patients, about 1.4%, who had received a DOAC within the previous 7 days. There was no difference in symptomatic ICH between the groups taking DOACs and those who were not. After adjusting for baseline characteristics and hospital factors, there was still no difference in symptomatic ICH between groups. The current guidelines recommend against fibrinolytics in patients taking DOACs within the previous 48 hours. This recommendation is based on the half-life of these medications and the estimated time to eliminate their activity. The use of stroke registries in this study limited their ability to determine the exact time of the last dose. So it's unknown how many patients had received a dose within 48 hours, and this may have affected their results if patients were included who had little anticoagulation activity on board. This study, published earlier this year, may help us fill some of those gaps. This was an international multi-center retrospective cohort study looking at patients with acute ischemic stroke who received fibrinolytics. Patients had to have a confirmed DOAC ingestion within 48 hours and were compared to patients not taking anticoagulation. The primary endpoint was symptomatic ICH within 36 hours of administration, and the secondary endpoint was any ICH within 36 hours. Over 30,000 patients were included here, with 832 patients who had recent within 48-hour DOAC ingestion. Patients taking DOACs were older, had more comorbidities, had higher NIH scores, more LVOs, and were more likely to be treated with thrombectomy, which suggests these patients did have more severe strokes compared to the patients not taking DOACs. Symptomatic ICH occurred in 2.5% of patients in the DOAC group compared to 4.1% in the group without anticoagulation. Any ICH based on imaging occurred in 18% of patients on DOACs compared to 17.4% of patients not taking anticoagulation. After they adjusted for differences in baseline characteristics, the DOAC group had a decreased risk of symptomatic ICH, and there was no difference in any ICH. We can speculate why patients on anticoagulation may have not been at an increased risk of bleeding. So anticoagulation may be aiding in the resolution of our occlusions, decreasing clot expansion, and maybe decreasing stroke severity. Patients on DOACs often have a diagnosis of atrial fibrillation. So in this study, 90% of the DOAC patients had AFib. And it may increase their risk for cardioembolic strokes. And these patients have a different clot composition compared to our patients not on anticoagulation. And our embolic stroke patients may have less blood vessel abnormalities compared to patients with atherosclerotic disease, leading to a reduction in hemorrhagic conversion. While this was a retrospective study with potential biases, it does show the potential safety and benefits of the use of fibrinolytics in our patients who are anticoagulated. So this does bring me to my last assessment question: which of the following is true? A patient receiving fibrinolytics within 7 days of a DOAC have been shown to be at an increased risk of symptomatic ICH. A patient receiving fibrinolytics within 48 hours of a DOAC are at an increased risk of symptomatic ICH. In a retrospective study, patients receiving DOACs had a decreased risk of symptomatic ICH, or the current AHA and ESO guideline recommends avoiding fibrinolytics within 7 days of the DOAC. So the correct answer here is C. So the retrospective study that was published earlier this year that we discussed on the previous slide did show a decreased risk in symptomatic ICH in those patients who were taking DOACs and received fibrinolytics. A and B are not true here because patients were not shown to be at an increased risk with DOAC use at 7 days or 48 hours. And D is incorrect because the guideline recommendations recommend against the use of fibrinolytics in patients who have received a DOAC within 48 hours. So looking to the future, we need a large randomized controlled trial to be able to feel more confident in the safety of fibrinolytics in our anticoagulated patients. Although a study of this size would take a lot of resources and several years to complete, and we may never be able to see this level of literature on this topic. The TEG6S system does correlate well with DOAC drug levels and shows promise in identifying patients eligible for fibrinolytics. Once that DOAC-specific cartridge becomes commercially available, it may be useful and practical for our patients. The majority of data on this subject that's available is looking at alteplase, so there's a limited information on tenacteplase in our anticoagulated patients, although tenacteplase has not been shown to have any additional risk of bleeding compared to alteplase. In conclusion, acute ischemic stroke patients who are anticoagulated with a DOAC may benefit from fibrinolytic therapy. retrospective studies have not shown additional risk of symptomatic ICH in our anticoagulated patients who are receive fibrinolytics. And patients taking DOACs who receive a reversal with idarucizumab prior to fibrinolytics have not been shown to be at an increased risk of ICH. And medication-specific laboratory values, when they're readily available, may be helpful in identifying and aiding our risk-benefit analysis for patients taking anticoagulation. Just to reiterate, in order to receive continuing education credit, you will have to fill out that evaluation that will be sent out later today. My list of references are here, and that concludes my presentation on critics of lytics, fibrinolytics, and the anticoagulated. I'll open the floor for any comments or questions. Yes.
So you have mentioned a lot of things involved in quantitative assessment and in this setting, do you think the key will be focused on the quantitative measures or qualitative, or do you think qualitative should suffice?
So Jason's question was asking, we talked a lot about quantitative versus qualitative measurements like laboratory values, and which one do I think would be better in this situation? So it's one thing that's very important for our acute ischemic stroke patients is time to that door to needle time and, door to treatment time. So there's only some few laboratory values that are available that can be come back quickly. If we had access to both, let's say, anti-10A levels and our TEG6S system. So anti-10A levels would give us a number versus our TEG6S system would say this patient's on anticoagulation or they're not. I think that the number would be more important, similar to our thrombin time that will exclude direct thrombin inhibitors. That's good to know, but I think having a number would be better if all things are equal in cost and time to results, to be able to really have that risk-benefit analysis for each patient. Yes, Jim?
You anticipate newer version of the American.
So Jim asked if I anticipate new guidelines to update based on this new data that has come out. I do think that this data is very compelling. Although it's retrospective, they have added recommendations or considerations based on retrospective data in the past. So I could see them adding something about being able to consider and have a broader recommendation on who to consider it than they have now.
I might have missed this earlier, sorry. What is the percentage of rollout that we have that necessarily, or would have received lytic therapy?
Yeah, so Jason asked, how many patients are we seeing that are otherwise eligible for fibrinolytics that are not receiving it because they're on a DOAC? So about 1 in 6 patients presenting with acute ischemic stroke will have that the DOAC be the sole reason why they cannot receive fibrinolytics.
So that previous slide that you had there was specifically they did not receive history.
Yeah, the 1 in 6, yes. That was just, they had an active prescription for it, so that was the reason they didn't receive it. I'd have to look more at exactly which 1 in 6 patients, but. So BB's question was, if we have a patient present to the ED who has taken a DOAC within, let's say, 12 hours, what would be our train of thought for that risk-benefit assessment? So Really, the patients that we're looking at are kind of the patients in the middle. So patients with very mild strokes with non-disabling symptoms. We're not considering fibrinolytics in those patients anyways. Patients who have really large vessel occlusions, they're probably may be candidate for mechanical thrombectomy. So IR would be the place we'd want to take those patients. There's better outcomes with that. That's where we want to go with that. The group of patients that we would kind of have this discussion in would be the patients who have pretty disabling symptoms, but they're not eligible for IR. So the only option we have for them is fibrinolytic therapy. And based on the data that we have, can we truly say that the risk is just too high to give these patients who are anticoagulated fibrinolytics? So I think that's where we'd have that like risk benefit assessment. You know, we have our laboratory values. If they're on dabigatran, I think it's reasonable to consider reversal with idarucizumab. If they're on one of the other medications, that's maybe where we say, again, risk benefit. Is this patient going to be pretty disabled and not have a good quality of life afterwards to the point where we're willing to take that risk? And I think it's a good question to ask, and that would be those patients that we would really consider fibrinolytics in. Yes.
So in real world practice, like, are you guys typically just using your data histories as the source of truth? Are you asking the patients if they remember what they that? What if they're really basic?
Yeah.
Like, just practicality. Like, if they can't give you correct answers and you're not using those data histories, are you guys using PTs for like Fibrinolytics, using calibrated NAs for
So Jason asked, for our patients in the ED, how are we determining if they're on anticoagulation or not? What references are we using? Are we doing laboratory tests? So the standard practice is to, first, if the patient's able to talk to us, then asking them. If they are either unable to talk to us or just bad historians, then we look at the data that we have in Epic and Care Everywhere to see if we can find recent fills with a DOAC or anticoagulant. And then if they're coming for some sort of facility, we can call them or look through that paperwork. And often family members are our next line. I will say that routinely we are not using like laboratory values. If we have a concern for anticoagulation that's on board, we usually hold off on fibrinolytics until we can make that like determination. Any other questions? Okay.
Yeah.
Yeah. Oh, yeah.
Yeah, it's Friday the 13th, and it's just like Michael and I have all together. Michael and I only have 2. So, yeah, we should go stop.
Oh, it's actually, but I'm like, I'm walking here, right, and well, yeah.
We can't put anything.
I might stop.
And you're honest,
Yeah. I don't know, I was, it was great, but. Yeah.
work. It's just between my hands and everyone's. You just have to get out for.
Yeah.
And we have to stand.
I'm sending you a thing, Heather wants to.
Oh, I'm sorry.
It's gonna go into the big stroke meeting.
Yes.
And it's
Scarlett,
outside,
y'all,
so
or
get your
Nicole,
slide-
actually.
get your slides in here too.
Okay.
Chat slide.
And why is this not showing?
Well, I like to add these things to my meetings, and then like B&B's coming in January, so we always want to do education.
I got one. This before. Thank you though.
Insta. Bye, good night. Thanks for coming, Heather.
I love it.
One big problem.
I know, right?
Like, how can, that's hard, I do this, you know, like, we have so many applications, and like, as soon as they bring another one, all right, I log in, see, oh, take another question, I'm like, okay, next.
Maybe it doesn't have to be that way.
I know.
But that would be a huge legal undertaking.
Oh, yeah.
It's like, who could be first?
Exactly. Who, yeah.
Everyone's, forever, it's not.
But I love it, this was all new info for me, so I love it.
Any questions?
Absolutely. Like, for real, do you want to be a guest in our CSC meeting and just do like a little mini thing? Like a little synopsis? Yeah. Yeah, for real. I love having like new people and guest people telling me.
That would be one deal.
I know, from, yes, and across the, like, yeah.